I'll get you to wave your hand as you go. So we've already heard from Professor Jackie Close. So Jackie, that's Jackie. And then Associate Professor Kath McDougall, Kath. And then we've also got Steve Murray, who's a geriatrician from up this way. And as well, Jamie Hallen. So Jamie is now standing down to make room for Nicole, who we've heard from in the last session, Nicole Lightbody, who's a CNC up here at school as well. And this, by not going on in order, I'm going to miss out somebody. So Associate Professor Rebecca Mitchell.
No, Rebecca's not here.
Also stepped out.
You've made some more space as well. So Beck's jumped out there. So unfortunately, probably one of the absolute brains trusts for the registry is Stuart Fleming, and he's our data guy. He's the guy who's actually created the back end and all of the things when you guys interact with the registry, when you look at the dashboards, all of those things. Stuart's your man. He's the guy that can problem solve just about anything when it comes to the interface between humans and data. Stuart is on a well-deserved holiday somewhere else where he's totally offline, so he's not available. So I'd just like to thank Stuart for all his hard work and wish he was here so I could ask him some hard questions, but he's not here, so I can't. So we'll get straight into the questions. So that's my job, is to look at this thing and read out what's been voted. I could ask questions all day about nutrition care, but I don't think any have floated to the top. So I'll go straight to the top question then, which is classic debate: should neck of femur patients be best cared for under geriatric cares pre and post rather than ortho care? Most complications are medical. Now, I would just like to say, did anybody see that graph that came up earlier with the care ratings for geriatricians? So I'm going to actually throw that one to our orthopaedic surgeon to start with. So, Kath, go for it.
Yes, shared care. It's clear, Jack, that this group of patients are a vulnerable, comorbid group of patients. Orthopaedics needs to be very involved, and there's lots of evidence that we should improve communication and collaboration. But the evidence is clear. The best place for these patients is in some sort of shared care ortho-geri model. Now, whose name is at the end of the bed? It depends a little on what the different systems are, but absolutely every hip fracture patient should be seen by ideally a geriatrician or physician, and in consultation with the orthopaedic surgeon, particularly in that immediate post-op period for the surgical stuff, the patient should be looked after that way. I don't think there's any controversy in that anymore at all.
Great. I might get you to pass the microphone to Steve, actually, and I'll give Jackie a chance. Steve, did you have anything you wanted to add to that?
No, I would agree. I mean, I think we're finalists, 3 years in a row now, and winning once, but I think that's because of the strong ortho-geriatric model of care that we have here. And our model is one where they're admitted under a geriatrician with the orthopaedic team proactively consulting and providing the definitive surgery, which of course is a necessary step. But I think that's the recognition that the hip fracture is a geriatric syndrome caused by frailty, falls and osteoporosis, and the hip fracture is a symptom of all of those things. And as the questioner said, all the complications that we mainly expect are medical in nature with the odd surgical complication. But that's why it's good to have good working relationships with the orthopaedic team. So when there are problems, that they can come and see these patients and provide that advice promptly. But yes, I would agree that it's obvious that the ortho-geriatric model of care is necessary and not just good practice, but a necessary component of care for these patients.
Now, you're passing the mic to Jackie, but just hold for a sec, Jackie, because I'm going to ask a nuance of that and then I'll go into the next question. So, Jackie, first of all, is an ortho-geriatric model of care just being seen by a geriatrician?
No. Can I answer the first part first?
Yeah.
So in terms of the model, I agree with Steve and Catherine. So orthogeriatric care is more than just hip fracture care. We need to acknowledge that. So just taking the hip fractures away from the orthopaedic surgeons, it takes us away from all of the conversations we have and those corridor conversations on the ward when you're looking and dealing with complex other non-hip fracture patients in older people. So I think orthogeriatric care is way more than just looking after hip fracture patients, and we are seeing more and more periprosthetic fractures, coming in. I mean, it's a measure of success in terms of elective surgery, in terms of being able to help people with quality of life for hips and knees. But the reality is, a downside of that is the periprosthetics. So having orthopaedic surgeons and geriatricians working on the same ward in partnership sends out a really powerful message to the whole team. And you're absolutely right, it is way more than just the two disciplines. It's absolutely about allied health and the relationship you have with allied health and with nursing. So to just take all the hip fractures away from the orthopaedic surgeon and put them in an aged care ward, I think we're missing the point of orthogeriatric care.
And I think that's a really nice summary. So you've heard from all three there that it's not actually, it's all about me. It's all about the patient, and it's about how that model of care actually integrates all of the right people to work together. And so yeah, thanks. That's really helpful. Actually, Jackie, the next voted question, so if you can keep the mic, it's addressed to you personally. It says, can Professor Close comment on the 78% adherence to the 48 hours to surgery benchmark, and how NOACs, Plavix affects this, and the expected impact of changing this to 36 hours?
So thank you. I'm sticking out my nose.
Sorry.
That's to help our colleagues who are dialing in. So,
Can I just check in the audience? Does anybody think it's a bad thing for us to move from 48 hours to 36 hours? I know there's challenges, but from a patient perspective, does anybody think it's a bad thing? No. So we just need to get over ourselves and realise that this is the future for us. We will never achieve 100% in terms of everybody getting through to 36 hours for a whole range of reasons, of which the DOACs just happen to be one. I think we're a lot more mature now in terms of understanding the DOACs. So Plavix should not make any difference. Like, orthopaedic surgeons will just crack on, won't you? Yep.
Yeah.
So the surgeons will just crack on with aspirin, and clopidogrel doesn't seem to bother them. I think also, I shouldn't really be speaking for you, but I will. You guys seem much more comfortable now operating on people with DOACs within 24 hours of admission to hospital. And there are some places where they won't even check levels, they'll just get on. Because the reality is, when you're waiting for the system to get rid of the apixaban or whichever it is, they're still bleeding from the fracture site. Yeah. So I think people are becoming much more confident now. We are tied by guidelines that are probably outdated in terms of 48 hours and then do a rivaroxaban level or a apixaban level or whatever. That's difficult. There is an international Delphi process going on at the moment, which hopefully will produce some pragmatic recommendations that will allow us to be a little bit braver in moving forward with operating on people on DOACs. But I don't feel that I should be answering the question for the orthopaedic surgeons, but we do not see a lot of bleeding with them.
I'm very comfortable now with the international guidelines that, I'd still like to, 24 hours after last dose for the DOACs. But we need to just get on and do it. And certainly the UK guidelines support that. They have a, consider general anaesthetic rather than spinal because of the potential of a neuroaxial bleed. But that's fine for me. And so that's the anaesthetist getting used to that too. But with all this evidence supporting us getting people operated on more quickly, I think we just get on with it. And I agree with Jackie. We've operated through clopidogrel and aspirin for many, many years, so that's not even a consideration. We obviously reverse warfarin.
Great, thanks. I might go on to the next question. So, and I might ask Carolyn to start off this one, just to make sure you're not stuck up the end, not answering any questions. And you've also alluded to this earlier, so you can speak more broadly to the concepts within this question, but do you think will there be financial penalty, and just think about penalty more broadly, if surgery does not occur within 36 hours? Talk to me about that.
I don't think the standards are about financial penalties, as we talked about earlier, and I think the fellow who asked the question earlier about elective versus emergency talked about the difference in pricing. Mm-hmm. I think the system is becoming more sophisticated into the future around how we do pricing in hospitals, but I think it just goes back to what we said earlier, which is it's the right thing to do. There's a whole lot more to finances than just the procedure itself. It's the length of stay, the complications in hospital, who they're going home with, what kind of services we have. So I think it's just not a black and white answer, and I don't think our Australian system there's not many. So the commission, one of the things the commission does is the Sentinel events. So Sentinel events means, and there's a list of 20 things, and it's things like chopping off the wrong leg is one of the, replacing the wrong hip would be a good example. When that happens, the federal government doesn't pay the state government. And then the hospital-acquired complications, there's some funding agreements in the National Health Reform Agreement between the states and the territories on how they deal with hospital-acquired complications. And then some states actually, so delirium's a good example, pass that on to the districts. The interesting thing about that is the hospitals are actually getting more money for the complexity of the patient than they are from the financial impediment of delirium. So they're actually better off recognising and treating delirium very well than not. So does that answer the question?
I think it's near enough. I think it's not just about coin, and data can drive, just the data itself can drive a lot of changes. So I might move to the next question, which I think will make it the last, just to keep ourselves on track. And apologies if I offend you with my grammar, but bums off the bed was a phrase I heard a little while ago from somebody who might be sitting on that table over there somewhere. But there's a few questions around the mobilisation and day one mobility versus actually just being offered opportunity to mobilise. And perhaps we can, let's just talk to the question, which is the Data Dictionary has transferring out of bed as one of the definitions for mobility. However, should the term mobility be further defined? So who wants to have a crack at that?
Take that, Jackie.
Okay, I'm happy to comment.
So there's a thinking behind the indicator, and there's a risk of overthinking this at this point in time. The whole ethos is that somebody, the day after surgery, their bum leaves the bed. Now, we'd prefer them to stand on two legs and be able to take a step. I don't think we need to overcomplicate it. I mean, the meaning of it is you get out of bed the day after surgery. If you take one step or 50 steps, the principle applies. Early mobilisation is good for you. Lying in bed is not good. So I don't think we should be overthinking this. The Data Dictionary is hard enough as it is, never mind more nuanced definitions.
I'm mindful we don't have any physios at this table. So do we have any physios, either pedantic or not, who want to argue against that? Or as we've heard, is that near enough? Like, any comments from the floor? Up the back. Yep. Oh, we'll need a mic just so that, Jamie, you'll run that one up, sorry. Right.
He needs to move down a bit.
I reckon you're a physio, so you're running up and down the stairs, aren't you?
In the instance where you've got patients with peripheral nerve blocks that limit the ability to be able to stand and take weight through both feet, the opportunity just to sit on the edge of the bed, I still feel is an option for us to consider as mobilising. It still gets the person out of the supine position, which for a number of patients they're really scared to do. So just being able to do that, I think, is probably the baseline of early mobilisation, and then anything beyond that is a bonus.
So I'll come in as a dietitian at this point, because I have nothing to do with either geriatrics or mobility per se, except that I try and look after the quads that get people out of bed. And when it comes to metrics and measurements, I think sometimes simple is better. And I also think that we've got to get over that mindset that we need to get to 100%. Because that's what people fear, is if we're not 100%, then that means we're not doing a good job. So there will always be those groups of people who it is appropriate, for example, that they don't get to theatre within 36 hours, and that's okay. So I think when you're looking at these things, try and be clinical pragmatist rather than an epidemiological or academic pedant, and I put myself in that box sometimes, and actually look at actually look at it from a patient-centred perspective, and then what is the, I guess, overall global feel of what it is the data's saying. Now, Lara, I am sorry if I offended you at this point as a fellow epidemiologist of mine. Okay, she's going to tackle me outside. And so at that point, I'm going to say thank you to our panel. You're done. You may be excused now.